Hello, please subscribe and like for our channel. Thanks very much. Hello, welcome to this new tutorial presented by the SchrDbb. In this tutorial, we're going to visualize this case of a 5-year-old boy who have this X-ray. Now, the first question say list the three abnormalities. Now, when you see this X-ray, you visualize the medial side of the lung. Is it clear? That medial side of the lung that is close to the trachea and close to the right bronchus, you see an opacity there that is very homogeneous. Is it clear? That opacity is called hilar opacity. Are you understanding? So you can visualize already one abnormality, which is hilar opacity. The second abnormality, we have blunting of the costophrenic angle. You see at the level of the costophrenic angle between the costal margin and the diaphragm. You see the costal margin and the diaphragm on the left side of the lung. Is it clear? You see the costal margin, the diaphragm, on the left side of the lung. But on the right side, you have blunting of the costophrenic angle. Now, you also visualize that there is something that is peculiar here. You see an air fluid level. Air fluid level is what? Every time that you visualize, normally, blunting of costophrenic angle is associated with what? A meniscus sign. And the meniscus sign is just like a downhill. When you put water in a small test tube, you realize that the water is going to having a downstroke. Is it clear? It's as if there's going a downhill. Is it clear? That meniscus that you see since chemistry that you were doing in laboratory and you were putting your test tube in a beaker until they were telling you that that inferior point was the part that you should measure. Is it clear? That one is the meniscus sign. Now here it is on a plateau. Every time you see a line, straight horizontal line like that, is it clear? It means that there is both air and there is fluid inside that lung. Is it clear? So those are the three abnormality. We have air fluid level, we have hilar adenopathy, we have hilar opacity, and we have blunting of the costophrenic angle. Now the next question says that what? List three important investigation. Every time you see this in a young child, you think of pulmonary tuberculosis, because pulmonary tuberculosis have different sign on the X-ray. Is it clear? The first sign of pulmonary tuberculosis on X-ray is going to be what? Going to be cavitations. Is it clear? You first have cavitation on the X-ray. The second sign of pulmonary TB on X-ray is going to be miliary pattern that we have done. You can see micronodular opacities, micronodular reticular opacity at the level of the lung field. Is it clear? The third sign of pulmonary tuberculosis that you see on X-ray is going to be what? Pleural effusion. Is it clear? Now, the fourth sign is pneumothorax. Is it clear? The fifth sign is hilar opacity. And generally, you have to know that what? Hilar opacities can also occur in another pathology, which is called what? Which is called sarcoidosis. Now, but the difference between hilar opacity in sarcoidosis and hilar opacity in pulmonary TB is that what? The hilar opacity in pulmonary TB is going to be unilateral, while the hilar opacity in sarcoidosis is going to be bilateral. And generally, you have to know that what? The hilar opacity on the left side of the lung, is a ringed shape, like a ring, and the hilar opacity on the right side of the lung is like a comma shape. Is it clear? If you look very well this X-ray, you can see a comma which is very wide, which is inside this opacity that was medial. I understand it. Now the next part is B. List three important investigations. Is it clear? So you are going to do investigation for pulmonary tuberculosis, which is your diagnosis. The first thing is a sputum acid fast bacilli. Second thing is sputum culture and sensitivity, and the third thing is the gene expert. Is it clear? Sputum gene expert. Those are the three major, or the sputum PCR. Those are the three major investigations that you do. Is it clear? To confirm your diagnosis. Now, to support the diagnosis, you can do other things like the Mantoux test, where you can confirm the diagnosis even with the Mantoux test, provided that you have certain parameters, because there are certain ranges. If you have a Mantoux test that is already more than 14, where you have induration that's already more than 14 millimeters, it's already possible for pulmonary tuberculosis. But now, when the ranges from 9 to 14, and you're a healthcare worker without any sign and symptom, you just have a latent tuberculosis and not a active tuberculosis. Is it clear? And if you have a mantle test of 9 to 14, but you are not exposed to any patient of pulmonary tuberculosis, you are said to have pulmonary tuberculosis. So there are certain criteria that the mantle test ranges. If you are between 0 to 5 millimeters, 5 to 9 millimeters, 9 to 14 millimeters, and greater than 14 millimeters, and certain risk factors, you are said to have positive. You are said to have either active tuberculosis or latent tuberculosis, or different tuberculosis type. Are you understanding? So that's where the mantle test helps. The mantle test can help distinguish a patient that is on active tuberculosis or latent tuberculosis. Now, the next thing that you have, give two important treatment modalities. When they say modalities, you speak about the means of management. And the two means of management here are you can have generally there are three means of management. You have general, medical, and surgical means of management, or you have general, pharmacological, and interventional means of management. As general means of management here, the patient has to be seated in a seated position. Why? Because when you are seeing this lung, you are seeing that the patient already has a respiratory distress, and to perfuse more the lung, the patient has to be seated. Exactly, that's one measure of management that's general. The second one is medical means of management. For medical means of management, you are going to start with anti-tuberculosis medication, and for pulmonary tuberculosis, we do 2 months of a quadruple therapy, which is made up of rifampicin, isoniazid, pyrazinamide, and ethambutol. 2 months of all that quadruple therapy, and then you do 4 months of bitherapy of what? Of rifampicin and isoniazid, knowing their different complications. Rifampicin as complication is going to have hepatic failure, is equal hepatotoxicity, and you have renal toxicity or colorization of the kidney, of the urine, is equal. The second thing is isoniazid complication is going to produce what? Is going to produce peripheral neuropathy and hepatotoxicity. And now to prevent that peripheral neuropathy, you have to do what? You have to give additional vitamin B6, which is also called pyridoxine, is equal. Now the third thing is ethambutol. Ethambutol causes eye blindness, is it clear, and optic neuritis. So to prevent it, there's no measure to prevent ethambutol complication. So the only thing is just to do a recurrent check for the eye vision and all that when you are giving patients anti-tuberculosis medication. The next thing is pyrazinamide. Pyrazinamide has hepatotoxicity, can cause pruritus, it can cause rash formation on the skin. Is it clear? So all that you have to visualize all these symptomatologies, check all these patients all through weeks when the patient is taking those medication. Is it clear? So those are the modalities, general and medical modality. Now, as interventional modality or surgical modality that you have to do here, you have to look very well that long. What do you realize? You realize that there is a huge pleural effusion. And now they are forgotten to tell you something that is very important here. In this, every time that you see an air fluid level, you think that there is both air and fluid inside the lung. That's why it's called air fluid level. And now every time there is air and fluid inside the lung, it means that the patient has both a pleural effusion and a pneumothorax. When you have pleural effusion and pneumothorax both together, it is called a hydropneumothorax. Is it clear? It means that there is both air and fluid inside the thorax. So you are going to do a drain here in order to drain that air and fluid. And the best way to drain air and fluid is to do an underwater sea drain. Is it clear? That you are going to do in this patient? You do an underwater sea drain. Is it clear? So those are the different things that you have to do for this first case. And when you do the underwater sea drain, you have to analyze again the pleural fluid. Every fluid that is being, or any specimen that is being taken from the body of a patient must be analyzed. If you are taking out urine from a patient, you analyze. You are putting even urine in a urine bag, analyze. Everything that you are taking out of a patient, the first thing you should have in mind is to analyze. So if a surgeon asks you, as you are taking this specimen out of the patient, what are we going to do? You say histopathology. Analyzed by histopathology. If an internist asks you as a question, as we have done an acetic tap, what are you going to do with this acetic tap? Don't go and say true. You have minus marks. So you say we analyze the the peritoneal fluid. Is it clear? Those are the different things that you have to do. Now let's go to the next question.